So Ratima, I think we can start now. Please, I welcome you to give the introductory comments.
Yeah. Good evening, everybody. I'm Dr. Ratima from the Gene-Evolve, the genetic testing division of Dr. Lal Path Labs. I welcome all of you on this webinar on genomic-based risk assessment in CML. Today, we have all the esteemed doctors as speakers and panelists in this webinar. Before I hand over the mic to our speakers, I would just like to introduce everybody. Dr. Purvish Parikh does not need any introduction, but still I would like to tell, he's the Chief Advisor of MOC, Precision and Medical Oncologist, Asian Institute of Oncology, Mumbai. We have with our international faculty, Professor Susan Branford. She is the head of Leukemia Laboratory, Assay Pathology, and the Center for Cancer Biology, Adelaide, Australia. Welcome you, ma'am. We have with us Dr. Hemant Malhotra. He is the Director of Oncology Services, Sri Ram Center of Super Speciality Cancer Center, and Professor, Head of the Department of Medical Oncology, Mahatma Gandhi Medical Institute, Jaipur. Then we have Dr. Puneet Jain, Consultant Hematologist from Apollo Hospital, Navi Mumbai. We have Dr. Rajesh Kashyap. He is the HOD, Department of Hematology, Sanjay Gandhi Institute from Lucknow. We have Dr. Soumya Sutta Panda, Professor, Department of Medical Oncology, IMS, and SUM Hospital, Bhubaneswar. Then we have Dr. Atul Tatai. He is representing Dr. Lal Path Labs. He is the Technical Director of the National Reference Laboratory Molecular Department. Then we have Dr. Ganesh. He is Consultant Hematologist, Bone Marrow Transplant, Yashoda Hospitals, Hyderabad. Dr. Shilpa Bharti, Consultant Hematologist, Parkview Super Speciality Hospital and Apollo from Kolkata. Dr. Jaydeep Chatterjee, Hematologist from HCG, Kolkata. And we have Dr. Prashant Mehta, the Senior Consultant and Head Medical Oncology, Asian Institute of Medical Sciences, Faridabad. Over to Dr. Purvish.
Thank you very much, Ratima. Thanks. You have already introduced Professor Susan Branford formally. But Hemant and I agree, and I'm sure all of you do, that today the laboratory valuation of a patient of CML cannot be done properly unless we follow the leadership that Professor Susan Branford and all her colleagues from Australia has put together. And therefore, we are really proud and privileged to have her presence live for today, and she is going to share with us her most recent thoughts on genomic-based risk assessment in patients of CML. Over to you, Professor Susan.
Thank you. I'll just start sharing my screen. Okay, so can you see my slides?
Yes, clearly.
Great, okay. So thank you very much for inviting me to talk to you tonight about mutations in CML. Now we know that CML is a genetically uniform disease where all patients have the BCR-ABL fusion, and tyrosine kinase inhibitors have substantially improved the overall survival. But not all patients respond optimally. There's a proportion of patients who fail therapy and progress to blast crisis and die, and optimal treatment of blast crisis remains an unmet need. So a better understanding of the mechanisms of treatment failure could lead to more effective therapeutic options for all patients. Now, it's long been known for more than 20 years that BCR-ABL kinase domain mutations are the main cause that we know of resistance. And about 50% of patients with acquired resistance gain 1 to 4 mutations within the BCR-ABL kinase domain. And the crystal structure is shown here with imatinib, very small molecule, binds with a very tight fit, and it just needs one nucleotide exchange in particular locations that can lead to resistance by interfering with the imatinib binding. And it does the same with the other inhibitors as well. And these can be very easily detected using Sanger sequencing. But of course, that means there's about 50% of patients who don't acquire mutations. And we don't have a great understanding of BCR-ABL independent resistance. And we know that BCR-ABL kinase domain mutations are not the cause of primary resistance, where patients fail to respond to treatment. So over the last few years, questions have been raised as to whether other genetic mutations that may be present at diagnosis or acquired during therapy contribute to treatment resistance and relapse. And over the last few years, genomic profiling using next-generation sequencing has become a standard practice for a number of hematologic cancers, where mutations can define different molecular classes, and these can stratify risk and assign therapy. And this is very well documented now in AML, where it's known that there's an abundance of different mutation types, including single nucleotide variants, gene fusions, and other mutational abnormalities that can cause resistance. And only about 3% of patients, there isn't a driver mutation that is identified. So we ask the question, just how frequently do mutations such as these occur in CML? And I'm going to show a few examples during my presentation. And here's one example of a patient that we monitored in one of the clinical trials of imatinib. This was a 21-year-old female who was diagnosed back in October 2002. She started with 600 milligrams of imatinib, but very rapidly progressed to blast crisis. And shown here is the plot of BCR-ABL over time, and she had no reduction before progressing to blast crisis. So we would consider that she had primary resistance. Now, back in those days was just when we were starting to test patients with resistance for BCR-ABL mutations. And at 6 months, we did detect a mutation. Now, this wasn't present at diagnosis, but because of the very rapid progression to blast crisis and knowing that mutations are not the cause of primary resistance, we asked whether she actually had another mutation at diagnosis. And fortunately, she did consent to future research for her sample. So we were able to go back to her diagnosis sample many, many years later when next generation sequencing was available. And we performed both whole exome sequencing and RNA sequencing to look for another mutation present at diagnosis. And we did indeed find an Idh1 mutation. Now, this mutation is now known to be a very common mutation, first identified in patients with brain cancer, subsequently found in patients with acute myeloid leukemia, and now have been found in CML as well. Although I must say that with further analysis, this is actually quite rare to find Idh1 or 2 mutations in CML. But we do know that acquired drug resistance in CML is a mutation-driven process. So not only BCR-ABL mutations, but now looking back at the literature, there is evidence that mutations in genes that we also find in acute and chronic myeloid and lymphoblastic leukemia are also present in CML. So we published a review back in 2019 where we looked at various studies who had either used Sanger sequencing of specific genes or next generation sequencing. And these are the mutations that we found at diagnosis in 15 different studies. Now, the most frequently mutated gene was ASXL1, and this was found in about 10% of patients. Now, we know from studies of other myeloid malignancies that ASXL1 is frequently mutated and it is associated with poor prognosis. And we published our study looking at diagnosis patients at diagnosis, and we selected patients for their extremes of response, either those patients who had an optimal response or those who had blast crisis. And we did indeed find that there was a higher frequency of mutations in these cancer-associated genes in the patients who had a poor outcome. And this has also been found in other subsequent studies. This was a study from Hammersmith Hospital, where again, it was a highly selected group of patients who were studied, responders versus no responders in patients who were treated with first-line TKI. And they found, again, significant differences according to whether mutations were present at diagnosis or not. And shown here is one of the graphs from their publication showing progression-free survival according to mutations at diagnosis for first-line imatinib. Significant difference. But interestingly, this study also included patients who were treated with second-generation inhibitors in the first-line setting. And in this case, there was no difference in progression-free survival. So I think this was a really important study because it provided some suggestion that perhaps treating patients with more potent inhibitors may overcome any poor risk associated with mutations at diagnosis. And in the advanced phase setting, accelerated blast crisis, again, we found many studies that had reported mutations at these disease phases. BCR-ABL kinase domain mutations were the most frequent. These were found in about 40% of patients, but there were 3 other mutated genes that were frequently detected. And these were mutations in RUNX1, ASXL1 again, and deletions in IKZF1. And collectively, these were more frequent than BCR-ABL kinase domain mutations. And interestingly, a few studies demonstrated that BCR-ABL kinase domain mutations rarely occurred without other mutated genes. A very recent study from Singapore last year demonstrated that blast crisis is characterized by additional translocations and deletions, and a number of studies have shown that blast crisis is also characterized by fusion transcripts, most frequently involving KMT2A, so this is the MLL gene, and again, this is the same types of fusions that are reported in other hematologic cancers. And in the largest genomic analysis of blast crisis CML, which involved 136 patients, and this also included previously published data, it was found that genomic abnormalities had a prognostic impact on overall survival. So what this study showed, again, was that ASXL1 mutations were frequent in blast crisis, and patients were divided according to whether they had a mutation in this gene or not. And there was a difference in overall survival for patients in blast crisis if they had an ASXL1 mutation. A similar analysis was performed for TP53 mutations and or deletion of 17p, and these patients had a particularly poor outcome compared to other patients if mutations in TP53 were not identified. And interestingly, they also divided patients according to whether they were treated with TKI-based therapy once the patients progressed to blast crisis. And they did find that those patients who received any TKI had a significantly longer survival. And they also included data from our study, and we were able to confirm this finding. So I think this was a really important study. It was very large, but it also showed the power of combining different data sets. Now, we published again our data, as I mentioned earlier, a couple of years ago, and we looked at 39 patients in blast crisis, and we detected multiple mutation types. So shown here are mutated genes where we detected what we would call fairly simple mutations. These are frameshift, missense, nonsense, and splice site mutations. And 72% of all patients had one or more mutations of this particular type in these genes that are shown here. But we also found a very high frequency of fusion genes. Again, MLL fusions were the most frequent. We found these in 31% of all patients. And we also performed copy number variation as well as RNA sequencing. And we were able to detect focal gene deletions, and again, at a high frequency in 36% of patients. So I think this was important to show that we shouldn't just look for these simple frameshift missense mutations, but gene fusions and deletions are also important. Now, we found that 58% of these patients in blast crisis also had BCR-ABL kinase domain mutations. But again, every one of these patients had one or more additional cancer-related gene mutations. So I think this is an important concept to understand, that BCR-ABL dependent and independent resistance mechanisms most frequently co-occur. So we don't have a group of patients that are driven solely by BCR-ABL mutations, and then another group of patients who have BCR-ABL independent resistance. These co-occur. And the reason why this is important is because over the last few years, there have been a number of targeted drugs that can target specific mutations in these genes or pathways. So I think this is going to be really important over the next few years, that potentially there will be new therapies for CML based on mutation profile. And I just want to go through one really interesting patient, showing that some patients have a very complex mix of competing clones. And again, this was a patient who was enrolled in one of our very early studies, diagnosed back in 2002. And again, at that stage, imatinib was the only TKI available. It was a 44-year-old male who, as you can see by this plot of BCR-ABL over time, that really had a poor outcome. BCR-ABL barely reached 10%, and BCR-ABL remained high. This patient did progress to blast crisis and died in 2006. So again, we were able to go back to the diagnosis sample of this patient, and we performed lots of next generation sequencing. We performed whole exome sequencing, whole transcriptome sequencing, copy number variation, and more recently, we've developed a targeted gene panel where we can detect even more sensitively mutations at diagnosis. So at diagnosis, we found ASXL1, and again, this is found in about 10% of patients at diagnosis have mutated ASXL1. But we also detected a mutation in U2AF1 at very low levels, and this was found by our more sensitive panel testing. Now, this is a splicing factor gene, and mutations in splicing factors have been identified over the last few years, and this was what we would call a hotspot mutation, so known to be associated with myeloid malignancies. And interestingly, as we perform next generation sequencing as well as Sanger sequencing over time, what we found was that it was this U2AF1 clone that expanded and evolved. And in fact, after diagnosis, we never detected the ASXL1 clone. So by late chronic phase, we had detected another mutated gene. This is the PHF6. It's known to be a driver gene, and the U2AF1 was a predominant clone. Now, this patient progressed to blast crisis, and again, the clone had evolved. This time, we had found a mutated RUNX1. This was a splice site mutation, and this affected splicing of this gene. And we also detected focal deletions within IKZF1. Now, this is commonly deleted in lymphoid leukemias, including lymphoid blast crisis, but it has been reported in myeloid leukemia, myeloid blast crisis as well. So I think this is interesting because these are more frequently seen in blast crisis. And this may provide evidence that it's the accumulation of mutations, including those with greater transforming potency, such as RUNX1 and IKZF1, that may be required for blast crisis transformation. But this patient, the clonal evolution was not finished. This patient was able to be treated with dasatinib and did have a transient response, but then progressed to a second blast crisis. And again, the leukemia had evolved and we detected a CBF-beta MYH11 gene fusion at that stage. And interestingly, it was only at that time, at the second myeloid blast crisis, that we were first able to detect a BCR-ABL kinase demand mutation. This is the common T315I mutation that causes resistance to dasatinib. So this was a really complex pattern of mutations. And in fact, this patient had just about one of each type of mutation that we have detected in various patients. So unfortunately, this patient didn't survive, but if we could go back to the time of diagnosis, now that we have different, more potent inhibitors, it raises the question, could a more potent first-line inhibitor for this patient with low-level mutant clones at diagnosis induce a rapid clearance of BCR-ABL? And perhaps this could have prevented the clonal expansion and perhaps even the death of this patient. And again, there was this study from the Hammersmith Hospital published a few years ago that suggested this indeed could be the case, that poor risk could be overcome with more potent inhibitors. So further work is certainly required to rationally assess the relevance of mutations at diagnosis and the circumstances when more potent inhibitors may achieve the best outcomes. So from all of these studies, this is what we know so far, that there are certain mutations and genomic rearrangements that could impact outcome. But there's still a lot of work to be done. And there's a lot that we don't know. We really don't know what the clinical relevance of mutations are at diagnosis until we have a look at an unselected consecutive cohorts and look for mutations at diagnosis and then assess the outcomes. We don't know whether some mutations confer a poorer prognosis or whether multiple mutations are worse than having just a single mutation. We don't know whether the poor risk can be overcome with more potent drugs. And we certainly don't know whether mutations at diagnosis will impact the chance of treatment-free remission. So there's a lot of work to be done. And to answer many of these questions, back in 2018, we formed an international CML Genomics Alliance. This has been facilitated by the ICMLF and supported by CML Patient Advocates Network. So shown here is just the groups who so far who have expressed an interest in participating in this. And so far we don't have anyone from India, but certainly anyone is welcome to participate with ideas or indeed contribute data. So our aim is to harness the wealth of genomic information that is generated in local CML research projects by building a platform to facilitate data assimilation, sample exchanges. We want to improve our statistical power to be able to answer some of these very important questions. So what we aim to do is pull data sets. We want to discover biomarkers that could predict treatment response and progression, guide drug use and development. We want to identify clinically relevant prognostic subgroups for enhanced risk stratification and provide evidence for informed expert international clinical practice guidelines. So we've recently partnered with a European-based a big data project, which is called Harmony. So this is a huge project that aims to accelerate the development of more effective treatments for people with blood cancers. And how it works is that it's a central repository of anonymized data for patients with various blood cancers, where multiple groups transfer their data, which is anonymized in a secure way, following all legal and ethical requirements. And then the data is available for approved projects. So originally, CML wasn't included in the Harmony project, but this was extended last year. This extension is called Harmony Plus. So we're now able to contribute data to Harmony Plus, and we put up a project to Harmony called the Clonal Hierarchy in CML. And this project has now been approved. So we've got a number of aims. We're looking to answer, again, these many questions that I raised earlier. We want to look at the importance and relevance of independent mutations at diagnosis. We want to be able to answer questions about the evolution of BCR-ABL independent clones during TKI therapy. We want to have a look at molecular aberrations during advanced phase disease, and even look at mutations in single cells in order to answer many of the questions. So this project was accepted by Harmony, and we're now preparing all of the processes in order that various groups around the world will be able to submit their data. So again, this is a 3-year project, and we hope that in the coming years, we will be able to combine all of this data to really strengthen the power to answer these questions. So I'm going to finish there. I'd just like to acknowledge the many people who have contributed, particularly the International CML Foundation and the Genomics Alliance, that have facilitated, hopefully, many fruitful projects that will occur over the next few years. And again, we welcome any contributions from India as well. And thank you for your attention.
Thank you very much, Dr. Susan. I think you have really done wonders by compressing decades of work in just 20-25 minutes and giving us only the distilled highlights. Hemant, would you like to respond to the contribution from India to the ICML Foundation?
Yeah, I think I represent the ICMLF from India, and whatever work has been done or not been done, I'm responsible for that. But we would be very happy to join the ICMLF, and we have lots and lots of patients of CML. You're already aware of that, so. And we have patients in every single stage of CML, whatever you want, newly diagnosed, in complete molecular remission, in partial molecular remission, with Idh1 mutation, the whole, across the gamut of CML populations, we have patients. So I'll send you an email, and we'll see how we can, get together and contribute to the knowledge of, more than just BCR-ABL in CML.
Thank you very much.
That would be great.
Right. So now the next session is our equivalent of the Tokyo Olympics. And this time the bout is between our two medal hopefuls, Dr. Puneet Jain from Mumbai and Dr. Rajesh Kashyap. And the topic is what Dr. Susan was alluding to, as to can we do something better for our patients if second generation TKIs are used in the first line for CML in chronic phase. For the motion, we invite first Dr. Puneet Jain to give his arguments. Over to you.
Good evening, everyone. Are my slides visible?
Yes, we can see and hear you.
Great. So first of all, thank you, Dr. Parikh sir. It's a great opportunity and always a very pleasant experience to come for talks and attend your talks whenever there are such sessions. And thank you for the organizers for this wonderful opportunity. So today's my session is on a debate for second generation TKI. So the topic is all newly diagnosed CML CP patients should receive second generation TKIs. As you can see, this is a battle across generations and no wild guesses as to see who will probably win. So looking at the treatment choices in CML in 2020, we have imatinib as a first generation. We have dasatinib, nilotinib, bosutinib as a second generation. Then we have ponatinib, we have omaxitaxin, and then asciminib as the newer generation, new TKIs that are in study. So regardless of the line of therapy, the treatment goals in chronic phase CML, it's to avoid progression to an accelerated phase or a blast crisis CML, such that patients achieve a life expectancy comparable with that of the general population, to minimize the adverse events, restore and maintain quality of life. And the most important prognostic factor, whatever TKIs we use, is to achieve these goals. Achieving these goals is the response to TKI inhibitors at key milestones, 6 months, 12 months, and so on. Let's look at some data on imatinib. This was a landmark IRIS trial. This was basically an open label multi-center trial with a crossover design, which was randomly assigned for patients with newly diagnosed CML in the chronic phase to receive either imatinib or interferon alpha plus cytarabine. Long-term analysis included the overall survival, response to treatment, and serious adverse events. The median follow-up was around 11 years. The estimated overall survival at 10 years was 83.3%, and 82.8% had a complete cytogenetic response, and almost a 10-year major molecular response was around 93%. Now, there were some red flags in the study. Those patients with a higher SOCAL score, a higher risk status at diagnosis, had a worse overall survival at 10 years, which was around 68.6%, than those with an intermediate score and lower score CML. Also, there were some deaths. Total number of 89 deaths that were documented in this study. Those who had responded to imatinib had a survival which was equivalent to the general population, but those patients with a higher SOCAL score were those who had typically died in this list of total 89 patients. Those who had a lower risk SOCAL score of CML the deaths were not mostly related to CML. There were secondary causes. Also, there was a large number of patients who had an unknown survival status, almost 20% of the patients in the imatinib group, or who did not have a molecular or cytogenetic assessment that could be evaluated. Thus, there was limitations in the long-term safety information that could be collected. These were the common side effects: facial edema, muscle spasms, nausea, vomiting, the GI effects. This had also led to adherence in imatinib, interruptions in the imatinib adherence. So the rates of imatinib adherence had been estimated to around 75 to 90%, and the lower adherence had correlated with a worse outcome. So in a study of 87 patients with CML CP treated with imatinib 400 milligrams, an adherence rate of 90% or less resulted in a major molecular response of 28% compared with 94% with greater than 90% adherence. So lower adherence had been described more in younger patients, those with adverse effects of therapy, and those who had required dose escalations. What about dasatinib? This was the landmark trial, the DASICION trial, five-year study. Here, 5-year analysis from the phase 3 dasatinib versus an imatinib study in the treatment At the time, again, there was 259 patients receiving 100 milligrams of dasatinib and 260 patients who had received 400 milligrams of imatinib. So at the time of the study closure, almost 61 and 63% of dasatinib and imatinib treated patients remained on initial therapy. The cumulative rates of major molecular response and molecular responses with the 4 and 4.5 log reduction in the transcript from baseline by 5 years remained statistically significantly higher for dasatinib compared with imatinib. So this primary outcome in this study was the complete cytogenetic response at 12 months. Those that were assigned to dasatinib achieved a complete cytogenetic response at 12 months more often than those assigned to imatinib. Also, there were some secondary endpoints of interest which favored the dasatinib arm. Now, also that dasatinib, the 5-year follow-up showed that that dasatinib induced more rapid and deeper responses at early time points compared with imatinib. Now, at 3 months, the higher proportion of patients treated with dasatinib achieved BCR-ABL transcript less than 10%, significant than imatinib, though later on, in spite of this study showing that this 3-month analysis showed a better progression-free survival and overall survival with dasatinib, there have been some studies which had shown that those patients who have achieved target value of transcript at 6 months may survive equally well as compared to dasatinib. So if you see the cumulative responses rates over time, this is the major molecular response, and this is the 4.5 log reduction. As you can see, at end of 1 year, 2 year, 3 year, 4 year, and 5 year, dasatinib 100 milligrams had induced deeper remissions in comparison to imatinib 400 milligram once daily. This was the forest plot showing the side effect profile. Major concern in 100 milligram dasatinib was the effusions that was almost 26 to the rate of 26%. But there was a higher incidence of facial edema, muscle spasm, nausea, and vomiting in the imatinib arm. So to offset this, MD Anderson had taken out, carried a study with low dose dasatinib. Which was carried out by Dr. Kiran Naqvi. Here,
can I request you to conclude now? Your time is up.
Yes, sir. So this, just to show, this is the lower dose of dasatinib, which had shown a better safety profile and fewer treatment interruptions. Just to show this, the first line phase 3 randomized study has shown that patients receiving second generation TKI achieve more rapid responses. Dasatinib and nilotinib treated have patients develop fewer mutations. Although rare, nilotinib treated patients have fewer progression to accelerated phase, and achieving molecular response at 3 or 6 months is associated with an improved overall survival and progression-free survival, regardless of the TKI. So this is a final slide. Low risk score. Patients can be opted for either of the TKIs, but a higher risk score or intermediate risk score should be preferred to be given second generation TKIs like bosutinib, dasatinib, or nilotinib. Thank you.
Thank you very much, Dr. Puneet. I now request Dr. Rajesh Kashyap to give the opposite viewpoint against the motion of why he says second generation TKI should not be the first line of choice. Over to you, Rajesh.
Yes, sir. So just a minute, sir.
Sure, please go ahead.
Yeah, thank you, sir, for the invite. And it's always a challenge for a physician when you have multiple drugs available in your basket as to which one should be an appropriate therapy for a patient. Similarly, in a CML, you always land up with a debate whether imatinib should be your drug of first choice, or now with dasatinib and nilotinib with the data coming on. So I just will try to give in a few minutes my perspective as to how I would rather prefer going with imatinib rather than looking in for a second generation TKIs in our patients' de novo CML. So whenever you think of a drug and you land up with a choice, whether it's a second generation TKI or imatinib, you always look into these parameters: the efficacy of the drug in the patient, the molecular cure, what is the survival, the long-term safety, and last but not the least, all across the globe, it is the cost effectiveness of the drug therapy. So already my colleague would have talked about this, and I just briefly said that since 2001, we have now used it for 2 decades, over 20 years, and imatinib has revolutionized the treatment. The life expectancy with CML treated with imatinib has reached more or less similar to the life expectancy of a normal person. This is from this SCER epidemiological data. So imatinib has proven that it is still the gold standard for the treatment of CML. Now, what are the short, and if you look at the IRIS study, which again I recapitulate, that overall the response rates have been 96% at 12 months. When you look at the 8 years and the 10-year study, sustained complete cytogenetic response seen in 53%, which is quite good. So at the end of the 8 to 10 years, and the loss of cytogenetic remission is around 15%. Than other types of mutation, and possibly from what Dr. Susan's talk, I can gather that many of these patients who actually have lost their complete cytogenic remission would be having an additional mutations which were not being studied at that particular point of time. So it would be worthwhile looking into it. And if you look at these data, the event-free survival is 81%, which is quite good for any cancer patients that we're treating. The overall survival of 85% is still excellent. And freedom, this is what we talk of, the fear psychosis of whether it's going into an accelerated phase or blast crisis, that the freedom from this progression is around 92%. So you only have an 8% of these patients who would probably, in spite of being on an imatinib therapy over a period of 8 to 10 years, would progress on to get an AP or a blast crisis. And this is where I think the data presented by Dr. Susan becomes more relevant, that you can actually stratify your patients that who are at the potential risk of having an accelerated phase, developing into an accelerated phase or a blast crisis earlier when compared to the rest of your patients. So this stratification now gains more importance. Now, when we compare to the newer generations of imatinib, let me just show you on this slide that what we talk of early molecular response, the major molecular response, the 4.5, the deep molecular response, dasatinib, nilotinib scores quite good over imatinib. So they're all significant. And this is what the data is always cited upon, that second generation TKI would be taken over. But we look at the overall survival and the progression-free survival. There's no difference between the imatinib and the second generation's TKI. The moot question remains as to why is it so? So there must be something else that is driving that, though we are getting a major molecular response, an early molecular response better with second generation TKI, but we have made no impact on overall survival and a patient progression-free survival. One interesting slide that what Dr. Susan showed was that if you have additional mutations, then when you compare a patient starting on imatinib with an additional mutation, have a poor overall survival with those compared without mutations, whereas with the second generation TKI, there is no difference in the progression-free survival, whether you had an additional mutation or not. And that's a very interesting finding. And I think that has to be looked upon into it. And that should be able to help you to plan out your treatment regimen. So that's important point. But here, this is what I would also like Dr. Susan to throw some light on it, is that why this major molecular response and MR2 4.5 is better with the second generation TKI. And this is what is driving our choice. But there's no impact on the overall survival or on the 5-year progression-free survival in these patients. So when we look at these two parameters, then I still think that imatinib is a good choice of drug. The next important point that one has to say is that most of your CML patients are in the 5th or the 6th decade of life, and they usually have this comorbidities. And this data from the shows that around 50% of these patients will have existing comorbidities, and around majority of them will have hypertension, cardiovascular disease, or diabetes. And you have to keep these comorbidities in mind before you think of starting your TKIs, whether it is the first generation or the second generation. And you see the impact of the mortality is not merely because of the CML, but it is also because of the presence of the comorbidities. So if you look at the comorbidity index, and then you decide and you see the patients with higher CCI, that is Charlson's comorbidity index, they do poorer who have more than, say, 2 when compared to those who have no comorbidities. So your choice of your drug should again be influenced by this comorbidity. The reason for this is because second generation TKI are not free from the adverse effects which impact the patient who are having comorbidities. Like if you have a past history of a lung disease, a pleural effusion, or COPD, you cannot use dasatinib. So these subsets of patients are out. Similarly, if you have pulmonary hypertension, dasatinib is out. If you have, this is now the complications that in country like India or in a developing country wherein about 1/3 of the population have coronary artery disease or a peripheral arterial disease or cerebrovascular, apart from diabetes, then nilotinib has to be used with caution. And the reason for that is, if you look at the incidence of a cardiovascular events with the use of nilotinib, as the period of years, say at 5 years, if you look the difference between the incidence with nilotinib increases when compared to those with patients on imatinib. So this is another major moot point. So you have a patient who has a cardiovascular disease or a coronary artery disease, you probably cannot be giving a long-term nilotinib beyond 5 years. Then what do you do? Even if the patient has an EMR or this major molecular response, should you switch back to imatinib? Some people say so, it is preferred. Then I would rather say then stick with imatinib rather than switching over to Tasigna or the nilotinib. So at the end of the day, I would summarize that in spite of good major molecular response and early molecular response shown with the second generation TKIs, there is no overall difference in the progression-free survival and overall survival with the second generation's TKI. So with the present amount of information and data we have, I would still prefer to continue imatinib, except for a small subset of patients who are younger, say below 45 years of age, wherein we would like to have a treatment-free response period, so that, say, if it is a lady with 40 years, I prefer to go on a second generation of TKI, give them for 3 to 4 years, and then give them a TFR and see that if they can plan a family. That's one way of it. Otherwise, I would rather recommend that give imatinib as a first drug of choice, keep the second generations of TKI as a next option to you, because you have nothing else to go beyond that. Thanks a lot. Thank you, sir.
Thank you very much, Rajesh. That was very interesting. I think this bout has been like the recent high jump in Tokyo Olympics. I think we will agree that both get the joint gold medal for this debate. It was excellent points brought out. Both of them had very relevant and important points. And it's now time to move over to the panel discussion. We have none other than our international CML expert, Dr. Hemant Malhotra, to be the moderator for this very important panel discussion. And as already mentioned, the panelists, esteemed panelists are our international speaker, Professor Susan Branford. I think it's now, past midnight for her. Dr. Prashant Mehta, Dr. Ganesh Jaishetwar, Dr. Shilpa Bhartia, Dr. Joydeep Chakravarti, Dr. Soumya Surat Panda, Dr. Atul Tatai, and both the debaters are also here, Dr. Puneet Jain and Dr. So over to you, Hemant.
Can I share my screen? Am I?
Yes, sir.
So thank you again, Dr. Susan, for being a part of this program and for a wonderful talk. And welcome to all my panelists. So we've heard a great talk on the new genomics of chronic myeloid leukemia by Dr. Susan. And we've had a debate in which we've thrashed out the pluses and minuses of the first generation TKIs and also the second generation TKIs. So now let's ask a few of our top hematologists and medical oncologists of the country some practical points and some practical aspects. So let's start the panel discussion quickly. Many, many thanks to my very dear friend, Dr. Parikh, for this opportunity and organizing this CML update. And here are my panelists, Dr. Susan, a very dear friend of several years. Many, many thanks to you, Sue. for being around at midnight for us. We'll try not to torture you too much. And here are my other panelists. This is the list which I was given. I don't think I have Dr. Atul's photograph here, but Atul is also part of our panel. We'll direct some questions to him also. So just to draw your attention quickly to and pay thanks to the clinicians and the pathologists and the laboratory scientists to bring this disease to a point where the people who have this disease have the same mortality rates as people in the general population. Dr. Parikh and myself, who've been in oncology for more than 3 decades, we'll remember CML patients where we had only busulfan and hydroxyurea with spleens, occupying the full abdomen, cachexic, and, just waiting to die. And with the discovery of the drug, we could see these patients, suddenly come to life and climb out of their beds and lead a few more years of normal life. So we have witnessed that, and let's, take a minute to thank the medical oncologist, hematologist, and the laboratory experts like Sue who made this possible. And I think this slide has already been shown to you. Across ages, across sexes, the patients with CML now have a life expectancy close to patients who do not have a CML, and comorbidities now dictate the life expectancy and not the presence or absence of CML. So let's do a few cases and thrash out some practical problems. So this is my first case. Please, my panelists, listen to this carefully. 38-year-old male farmer presented in early 2013. Yeah. Does anybody have a comment?
Please go ahead, sir. Prashant is just on the phone.
So do you feel like singing a song, Prashant? Maybe afterwards, right? So the patient presented in 2013 with a 4-month history of malaise, weakness, anorexia, lump in the abdomen, massive splenomegaly, low hemoglobin, very high counts, increased platelets also, 2% blasts in the peripheral blood, and 2% basophils and 4% eosinophils. Marrow was hypercellular, shift to left, 4% blasts, 3% promyelocytes, so not into the accelerated or the blastic phase. PH chromosome was positive, BCR-ABL was positive, and his BCR-ABL quantitation on an international scale was 68.9. So we had a final diagnosis of CML chronic phase, high Sokal risk, high UTOS, high Hasford, and intermediate risk ELTS. So in addition to the usual hydration, allopurinol, hydroxyurea, which we use to prevent tumor lysis and get the counts down, how would you approach this patient? Let me ask Soumya this. How would you treat this patient, Dr. Soumya? Imatinib standard dose, high dose, dasatinib standard dose, low dose, or nilotinib or busulfan. Dr. Soumya, are you there?
Yes, sir. I am there, sir. Sir, this patient is a high-risk Sokal, and I don't find that there is mention of any comorbidities. So I would like to go to the second generation TKI, preferably nilotinib 300 milligram BD.
Okay. So any other inputs from any of the other panelists? Ganesh, you are an acknowledged CML expert, and your publication in the JGO is a classic from our country. Any inputs from your side? So is Dr. Ganesh on board?
Yes, sir.
Please go ahead. Tell me.
Sir, look, this again, as the options are variable at our disposal, but this is ELTS intermediate risk young, relatively young patient, no comorbidities. So I'll go for second generation TKI with dasatinib standard 100 mg. And if there is a issue, then only I'll switch over to 50. Okay, so is there anybody here on the panel? Dr. Soumya and Ganesh have already opined. Dr. Shilpa, Joydeep, Prashant, Atul. Anybody has a difference of opinion? Second generation TKI versus imatinib. Anybody would like to think of imatinib in this patient?
Prashant, you agree that you would start one of the second generation TKI?
I think I would be inclined towards the second gen here. It's a young patient.
Yeah, and which second generation TKI would you choose out of the three which are available to us?
Now we have a generic dasatinib available. It's a cheaper option, so I think most of my patients are using that. It's okay, 100 mg standard dose.
Standard dose, right?
Yeah, not low dose.
So, Joydeep, would you like to comment on the concept, which is, I don't know how it has come to become popular, that 50 milligrams dasatinib is an equivalent to 100 milligrams. Would you like to comment on that? Send a message to our young people that 50 milligrams, is that okay for a newly diagnosed patient?
I think, given this high risk, and I am still not comfortable with starting off at 50 milligrams. I would most probably agree with Prashant, and we would most probably start off with 100 milligram dasatinib. We will see how he is tolerating, what his counts are, what his complications are, and then go on to dose reduce, as per titrate according to patient tolerability and the bloods.
So I think we as a group today should send this absolutely unambiguous message that if you are starting dasatinib in a newly diagnosed CML CP patient, then as of just now, as of today, the standard dose is 100 milligrams once a day. You need to do 50 milligrams only if the patient has really significant comorbidities or the patient shows intolerance to the 100 milligram dose. So I think absolutely unambiguous message should go that this dose, 50 milligrams, is still under study. There is some nice tantalizing data from a single institution at the MD Anderson, but we still have some time and some more inputs needed by randomized studies to be able to be sure that these two doses, 100 versus 50, we are talking of dasatinib, are equivalent. So now this is again a question. Let me start with Dr. Atul. Atul, would you ask for a BCR-able kinase domain mutation testing at diagnosis? You've already heard Dr. Susan's talk, and there is some little bit of additional information to be gained, but would you, as a standard of care, think of mutation testing at diagnosis either by Sanger or by NGS?
So my background is that I am a lab person, but in our lab, what we clearly see is that people do not order this as at diagnosis, but it is usually ordered at a relapse.
Okay, I think again, let me ask one of our clinicians, Dr. Shilpa. Shilpa, would you like to answer this question?
Yes, sir. So we are not currently doing it at upfront at diagnosis. We are sticking with clinical local score. If they are showing early resistance or progression of disease on treatment, only then we ask for the domain mutation.
Right. So I think again, as of today, the standard of care is that you don't need to ask for a mutation testing at diagnosis. But you heard Dr. Susan and the consortium which she has formed, and which a lot of people are working on. We may have a change of recommendation in the coming few years. Sue, are you there and still awake? Can I ask you?
I'm still awake. Yes.
Yeah. Can I ask you, like, is it okay to ask for a Sanger sequencing, or should all patients be now tested by the NGS?
Well, we're still using Sanger sequencing. It's quick and reliable. So we can detect around about a limit of sensitivity of 10% BCR able. And certainly over the years, we have found that when a patient is showing signs of resistance, usually the kinase domain mutation is detectable by Sanger. So yes, there may be some benefit in patients who have failed to achieve a certain response, that if you use next-gen sequencing, which is more sensitive, you may be able to detect 3 to 5% mutant. There may be some advantage in finding that mutation slightly earlier.
So thank you. And I think it's reassuring for us to know that one of the most advanced CML treatment centers in the world, Adelaide, they are still as a first line using Sanger sequencing. And we don't need to, be obsessive about asking for deep sequencing in all our patients. Any of my panelists have an opinion on this, Sanger versus NGS? Anybody can come in?
Can I just say something as Joydeep here?
Yeah, please go ahead, Joydeep.
Professor Malhotra, I have been doing NGS for my new CML patients for the last 2 or 3 years now. The practical issue is that doesn't change what you're going to select initially for treatment. I still, it is still taking me 14 days, 10 to 14 days for the reports to come. Very, very interesting reports to come. And if Professor, I had written to Harmony also that from HCG, if you can collate the data, haven't had a reply from Harmony as of yet. But some very, very interesting sequences coming out of the NGS. But what we are seeing is that, that is not really affecting my initial treatment of choice in these patients. So I'm still have to rely on my SOCAL, my other scores for that. And then it's taking at least 10 to 14 days to come into it. And by that time, when you go and tell the patient, no, you had selected a wrong treatment initially, that doesn't look very good, especially if the patient is responding.
Okay, so I think Harmony is with you today in the sense that Sue is attending this meeting with us. And then, maybe we can make a joint effort from our country and try and be part of the consortium and contribute to the CML, global CML knowledge. So let me ask Prashant this question. Prashant, for the young patient with high risk SOCAL, out of these 5 goals, there could be more also. I mean, I don't have all of the above in this. What would you choose as your number one goal? So say for a patient who is 35 years old, like the patient which we are discussing.
So yeah, preventing progression is for a high risk SOCAL, yeah, you're saying, and a young patient. Preventing progression is one of the important goals, and also obviously the others are important. So, but yeah, preventing progression for a high risk SOCAL seems very important to me.
So as far as you are concerned, number one would be the answer to this question.
Yeah.
Can I ask the same question to Dr. Soumya?
Sir, if we don't have all of them over here, so for me again, high risk SOCAL, I'll try to prevent progression to accelerated phase or a blast crisis.
So, okay, I think the obvious answer to this is that we would like all these 5 things to happen in our patient, whether the patient is young or old, whether the patient is high SOCAL risk or low SOCAL risk, right? So, like this is some data which has already been shown to you, and a snapshot of the 5-year results of the Decision trial. You have the dasatinib in blue and imatinib in yellow. The first panel is patients with major molecular response, and at 5 years you can see a statistically significant difference, 64% versus 76%. And in the panel on the right, you can see patients with MR 4.5, and again 33% with imatinib at 5 years versus 42%. And after the separation, after a year or a year and a half, these curves are not looking as if they are going to get together if you do a further follow-up. The study is now closed, so we are probably not going to get a formal further analysis, but it appears to be that this is the case. Now I have a question to Dr. Atul, our representative from the laboratory on our panel. Atul, what do you make of the digital droplet PCR? Is that a significant advantage over our standard RT-PCR? And should we be shifting or thinking of shifting to digital droplet PCR rather than our standard RT-PCR? Dr. Atul?
So my views would be that, see, end of the day, sensitivity matters a lot while you are looking at a BCR, ABL, or any of these translocations. The more sensitive the assay, the more earlier we are able to pick up and help the patient out. So as of now, the guidelines do not per se recommend ddPCR, but yes, definitely it adds to the sensitivity of the assay, and we should be shifting in the coming years to a more sensitive assay like ddPCR. With current technologies, we are able to go down to 4.5 to 5 logs reduction, which is good enough with the current guidelines in place.
So, Susan, would you like to comment on that? You were one of the pioneers in developing and testing the digital droplet PCR. How different, how difficult, and how much additional information does it give? And what do you think would be the usage of the new technology?
Yeah, so actually we're still using the real-time PCR. Certainly I know that digital droplet PCR offers more precision. So, you know, that's a good thing. Certainly we know that reverse transcription PCR gives us a lot of variation. So by all accounts, the digital droplet PCR offers a more precise result. And that can be important because, you know, in CML, we've got very defined cutoffs that define an MMR. So the more reliable the result, the better. So I think that's one advantage. And certainly, you know, there's a lot of factors that come into it, cost, etc. But also there is at least one kit on the market that is standardized to the international scale. So I think that's a very good thing as well. So I think that this can offer some advantages, and certainly I don't think there should be barriers to using either method.
So do you think that when you are thinking of TFR and when the patient is undergoing the TFR, then the restart trigger might be more fine-tuned if you do a more sensitive test? Do you think there is a usage in that setting?
Maybe not, because, you know, certainly a trigger for stopping, for restarting, in the vast majority of patients, there is quite a rapid rise. And if you're monitoring monthly, you can actually see that consistent rise over a month. In the cases where there are patients who have fluctuating BCR-ABL, that may be the advantage. We do see the rare patients who are positive, but their levels remain below 0.1%, which is the trigger to restart. So there may be some advantages there with a more precise assay. So it may reduce the degree of fluctuation that is seen. So you're more confident that the patient is stable and no need to restart.
Thank you very much. So this is the 10-year results with the first line nilotinib study. And then you can again see we're talking about MR 4.5. And these are the 2 doses of nilotinib, 300 BD and 400 BD, which were used in this study. And again, both the arms of the second generation TKI at 10 years is significantly better in producing MR 4.5 as compared to imatinib. And this is the bosutinib first line study. And you can see again in a bar chart form that MMR as well as MR4 as well as MR 4.5 is significantly more in the second generation arm as compared to the first generation imatinib. And all of you are aware that bosutinib now is available in India as a generic form. So this again is a significant option for our first line and our second line treatment. So here are the 2, more commonly used second generation TKIs, nilotinib and dasatinib, compared with imatinib. And you can see that across the board, whether you talk about complete cytogenetic responses at 12 months, or MMR at 12 months, or MMR at 5 years, or CMR at 5 years. We don't call anything as CMR now, MR 4.5 at 5 years. Imatinib is significantly, nilotinib is significantly better, and you can see the % gains over here, as well as dasatinib is significantly better as compared to imatinib. However, survival at 5 years, there is even though the numbers might appear to be slightly different, there's only a 2% difference, and this is not statistically significant. both for nilotinib as well as dasatinib. So it is possible that as further follow-up happens, you might see an overall survival advantage. But as of just now, and it has been very clearly highlighted by our two debaters, that as of just now, the second generation TKIs do not offer a survival advantage, at least over patients who are on nilotinib. Now, this is something which is very important. Most of our patients, at least 70 or 80%, will not be candidates for TFR. They will have to continue the medication for possibly lifelong or at least several decades. And each one of us should be aware of the toxicities of these agents. So let me, quickly, I think this is very, very important that practicing physicians and hematologists and medical oncologists be aware of these toxicities and look for these toxicities. Let me quickly ask Dr. Shilpa. Shilpa, for a patient of yours who's on imatinib for say 10 years, and there are quite a number of patients now who are in their second decade with imatinib, what would you look for? What long-term toxicities would you look for?
Yes. So for imatinib is generally, I think, the toxicities when they are there, they are quite apparent immediately. Most of them who are intolerant, within the first few months, whether they are tolerating imatinib or not. But in the longer term, we have seen them having problems with, I have seen patients who have been on long-term imatinib having significant GI toxicity. They've had significant diarrhea and have lost significant amount of weight. Although their disease is very well controlled, they are in major molecular and deep responses, but they have significant GI toxicity. A lot of them have even have problems with, significant and severe hypothyroidism. But GI toxicity is something that has been most extensive with imatinib on a longer-term basis. In the shorter run, of course, fluid retention, joint pain, a lot of them have discontinued due to arthralgia.
And I think particularly in the long term, the renal effects are now being recognized. So it is recommended that every 3 monthly or every 6 monthly when the patient sees you, you should look at the urine examination and also get the renal function test done. Now, can I ask Dr. Soumya to elaborate on the nilotinib long-term toxicities and focus on the cardiovascular vascular toxicities?
Yes, sir. So nilotinib, while giving nilotinib, we have to be very careful that it has got a black box warning of QT prolongation and it has got significant vascular events. So patients need to be monitored for any peripheral arterial disease or any ischemic heart disease. And we must warn the patient regarding to check the glucose levels and the serum lipid levels. So there are a number of toxicities, especially the vascular events that has to be monitored while giving nilotinib.
Absolutely. And my practice is that every single patient who's on nilotinib, every time he or she comes to visit me, I make a checklist and look for peripheral vascular disease and cerebrovascular disease and cardiovascular disease, and all the secondary preventive measures for vascular disease have to be initiated on all the patients on nilotinib as soon as you start the medication. So you must tell them not to gain weight. You must tell them to regularly exercise. You must tell them to keep their sugar and their lipids under control and be a little more aggressive in starting statins. And that should be done for every single patient, whatever the age of the patient who is on nilotinib. And now can I ask Prashant? Prashant, for a patient who you're planning to give dasatinib and dasatinib for several years, what long-term toxicities would you consider?
So an important and sometimes irreversible toxicity which can happen with dasatinib is the pulmonary artery hypertension. So that is one important concern, and that I think should be explained at the outset if you're choosing dasatinib. So that is one concern. Apart from that, yes, the known cardiovascular and obviously the slow decline in kidney function, the viral reactivations, all that is a concern in the long term. And we need to keep a watch at all these organ functions also, along with the usual common toxicities which happen initially but not later.
Yeah, and I think, lymphopenia and natural killer cell suppression is the maximum with dasatinib out of all the first and the second generation TKIs. And sometimes some rare, unusual infections can happen in patients with dasatinib, skin infections, very strange and odd fulminant tubercular infections,
Agree.
Fungal infections. So you have to keep that in mind, and you have to consider dasatinib as one of the agents contributing to altering the immunity in such a way that the patient is prone to chronic infections. That also needs to be kept in mind. So now we have a new kid on the block also. Bosutinib is available to us. We have less hands-on experience with this drug, even though I was one of the investigators in the first Bela trial. Let me ask Dr. Joydeep. Joydeep, if for a patient you are starting on bosutinib, because this agent is relatively new to us, what acute and what chronic toxicities would you think of? And would you request your physician colleagues to monitor?
Yeah, I would say that the GI toxicity with bosutinib is quite profound. I've seen patients coming with diarrhea, especially if you're going on the very high dose, the recommended dose. But I feel that among all the TKIs that we have, it is most probably most gentle to the hematopoietic cell line. So, if I've got problems with nilotinib, dasatinib with counts and imatinib with counts, maybe bosutinib at that point is an alternative also. Transaminitis and liver issues are there. It's with all TKIs, but maybe a little bit more with bosutinib. But for my patients, especially post-transplant patients also, I've not had too much problems with bosutinib so far.
Thank you very much. So, as we get more and more experience with using this new drug, then again, our familiarity will increase and our, usage will increase. I'm quite sure about that. So, Purvish, how much time do we have?
Hemant, please continue for another 10 minutes, please.
Come again, please. I can't hear you.
Up to 10 minutes is fine.
More 10 minutes more?
Yep.
Okay, great. So now let's talk about a very young female patient, classical CML, again, high-risk disease, large spleen. In fact, this data I've, just extrapolated the patient which we've already discussed, but only the patient is young now, 28 years old, female, and she has one female child and is desirous of more children. She has high-risk CML, high focal risk CML. She's been started on dasatinib 100 milligrams per day because our goal has been to get the patient into a quick hematological and molecular remission and think of a TFR. So she's been on the treatment for about maybe a year. She's had an optimal BCR-ABL at 6 months. So she is in major molecular response. And then one fine day, even after your counseling, she comes and tells you that, doctor, I have missed my periods 6 weeks back, and my urine test is positive for pregnancy. Now, what would be your advice to this patient? Let me start with Dr. Shilpa. Shilpa, what would you do? Would you continue the pregnancy, continue dasatinib, continue pregnancy, stop dasatinib, advise medical termination of pregnancy, and then continue dasatinib? Or would you do something else? And please remember that this patient is 28 or 29 or 30 years old, one female child, wants one more child. Dr. Shilpa, are you there?
Really desirous of this pregnancy, and for us, it's a bit early. We would want her to have been in a deeper molecular remission before we would have advised her to go ahead with the pregnancy. None of the TKIs have got established data on safety in pregnancy, although there have been patients who have continued imatinib and have had uneventful pregnancies. But yes, she needs to stop the dasatinib first if she wants to continue the pregnancy. We may have to consider, giving her other options like use of interferon in pregnancy, but she cannot continue dasatinib.
So your choice could be option number 2. You continue the pregnancy and stop dasatinib. Is that right?
Yeah, if she were, but I would want her to be in a deeper remission. So 6 months back, her BCR-ABL was 0.2. Would we know what her current molecular status is and how long she has been on therapy?
About a year.
Bit early. It depends. Yeah, how deep a remission is at that point of time. It's something definitely she's going to have to stop dasatinib, and we have to think of interferon and see how she tolerates it. She's only 6 weeks into a pregnancy. There are high chances of pregnancy loss as well. So it's going to have to be a discussion between you.
Agreed. But what would, okay, let me ask Dr. Prashant. Prashant, what would be your advice, 1, 2, 3, 4? And I want an unambiguous answer.
Yeah, so I would first suggest that she, probably consider undergoing MTP and continue dasatinib. That would be my preferred advice. And I would say that try to achieve a TFR and then try to get pregnant again and then have a child.
So I think I would completely agree with you that as far as medical professionals, our unambiguous advice to this patient should be to get the pregnancy terminated, because the fetus during organogenesis first trimester has been exposed to a TKI, and we know that the fetotoxicity rate, the rate of teratogenicity, is between 10 and 15%. So our unambiguous advice should be number 3. And if the patient does not heed your advice, then it should be documented on your case papers. And then, of course, the patient and the patient's husband and family is at liberty to do whatever they feel like. But our advice unambiguously should be number 3. And Joydeep, would you agree, or would you have a different opinion?
No, I absolutely agree. She needs to terminate at this point.
Ganesh, what would be your advice? Because this does happen reasonably common.
We are in 2021. She's just 29-year-old young lady, and she already had a child. Whatever minimal risk of any teratogenicity, at least from our part as a treating physician, I will advise for MTP strongly. And she's just into 1 year of her CML therapy, even though she has achieved all the milestones as per the expectations. But yes, she's in just 6 weeks of pregnancy, 29-year, already had a child. I will strongly recommend for MTP, unless and until she is strongly desirous of continuing the pregnancy despite all the risk after extensive discussion, and I'll definitely continue dasatinib because she's just 1 year into her.
Absolutely. So I'm very happy that all our panelists are on consensus on this, and I think this unequivocal message should go from our side that if a patient conceives and has been taking TKI during the first trimester at least, then the chances of fetotoxicity and teratogenicity are too high to accept, and our recommendation, at least on paper, whether the patient follows that or not is another story, should be MTP. And in this particular patient, she is young, and once we have a deeper remission and a longer exposure to the TKI, then she can, have a shot at TFR. Not just now; it's only 12 months just now. After 3 or 4 years of exposure to the drug, she can have a shot at TFR and then a shot at reconception, right? Okay, so I don't know whether we have time, but very quickly we'll go through this. This is a 50-year-old gentleman who has chronic renal failure because of hypertension. His urea is 98, his creatinine is 3.2. Otherwise, he has CML CP with high Sokal score, same parameters as last time, but he has CRF with a creatinine clearance of 28. So now what would be the best treatment for this patient? Standard dose imatinib, reduced dose imatinib, dasatinib, standard dose reduced dose, nilotinib, standard dose reduced dose, bosutinib, standard dose reduced dose. Let us start with Dr. Soumya this time. Soumya, what would you do a patient who has mild to moderate renal failure and high Sokal risk CML CP?
Sir, probably I'll go with imatinib 400 milligram, but I do need to check the pharmacology before prescribing that. But what I remember is imatinib is safe here.
Dr. Joydeep, what would be your choice?
I think there shouldn't be any dose reduction for dasatinib with renal failure only. And this is a high-risk CML. why don't we, think about dasatinib here at full dose?
Yeah, I recently, a couple of months, had this patient come, and I actually didn't know what to do. So I had to pull out some literature. And, that's why I kept this case in this particular panel. I kept it in another panel a few months back also, because the awareness about this is a little less. And I'll tell you what my literature search showed. So we're talking about CRF and TKIs, imatinib and its metabolites are not excreted via the kidney to a significant extent. Patients with mild to moderate renal dysfunction should be treated with caution and be given the minimum recommended doses of 400 milligrams. And then you have to very carefully observe the patient's kidney functions. If the patient has severe renal failure, creatinine clearance of less than 20, then possibly imatinib should not be used. Then what about nilotinib and dasatinib? There have been no clinical studies on these agents, but all the clinical trials have excluded patients with serum creatinine of more than 1.5. And we do not know what happens to the metabolites of these two drugs. So it's still a big question mark whether these drugs should be used or not used, right? So like the literature doesn't help you. And if you do decide to give one of these agents, then you will have to, take a lot of responsibility on your own. And what about the bosutinib? In patients to moderate renal failure, creatinine clearance 30 to 50. The recommended dose is 300 milligrams per day, not to be used if creatinine clearance is less than 20. Or in fact, if it is less than 20, then you can further reduce the dose. This is the product insert of the molecule. So, my choice for this patient would be either imatinib or bosutinib, because I have a recommendation, and based on some hard data, that dose reduction might be safe in renal failure. And of course, you have to, whatever agent you use, you have to monitor very carefully the kidney functions, maybe every weekly initially, and then settle down to twice a week, twice a month, or once a month. So this is the table for you, creatinine clearance here, and all the agents should be used very carefully or not used. If the creatinine clearance is very low, the only recommendation is to use 20 milligrams, 200 milligrams per day of bosutinib. So you might need to keep this in mind if you have a complicated patients like this. So like with the permission of the organizers and with my very, very brilliant panels, I'd like to conclude. We have 2 minutes to finish, and I know that Dr. Parikh likes to start on time and likes to finish on time. So life expectancy of patients with CML is now approaching that of age, sex-matched persons who do not have CML. But this is only true if expert management of the disease is done. So I think this has to be underlined. Each one of you is an expert, but unfortunately, all patients of CML are not treated by you and me. A good 60% of patients are treated by physicians, and it is, the responsibility of each one of us to, try and educate our physicians. So CMEs like this, which Dr. Parikh has organized, webinars like this, are extremely important. And I circulated the link to my physician group, and I hope some of them are watching and learning a little bit as to how to achieve this normal life expectancy of this patient of CML CP. So we now have several options for treating this patient. We have second generation TKIs available in our country. And we have also realized that TFR is a goal for a smaller number of patients, maybe a quarter of all our patients, particularly if they are young. You don't want to expose them to a TKI for 20, 30, 40 years. So TFR should be thought of in the younger patient, maybe not so much in the patient who is 60 years or 70 years, and should be thought of right at diagnosis in a female patient, particularly if she is desirous of having more children. Then the choice of TKI in the newly diagnosed patient will of course depend on cost, comorbidities, convenience, and toxicities. So all of us are aware of this, but this needs to be highlighted and discussed with the patient every time. So with that, Lana, I'd like to close. And once again, thank you very, very much, Susan, for being with us. Your first talk was very, very illuminating. I learned a lot of new things about that. Thank you for staying awake till midnight for us. And we will keep in touch with you. Thank you very much, each one of my panelists, for their wonderful contribution, and Dr. Parikh for organizing this. And I hand proceedings back to Dr. Parikh. And we report on time arrival, as they say in the airlines.
Thank you very much, Hemant. I think the panel discussion was very interactive, but we still have one speaker. So without wasting much time, can I hand over to Dr. Atul? Please let us know why we should send the lab with send the sample with complete confidence to Lal Path Lab if we want to do genomic based risk assessment of our patients with CML. Over to you, Atul. Dr. Atul is there?
Dr. Atul, you'll have to unmute your mic, sir.
Yes, sir. Are my slides visible?
Yeah, we can see them.
Yes, sir.
Yeah. So I know we are just on schedule, so I'll just rush through my slides, and most of these slides are very journal in nature. So basically, we know that what CML stands for. It is a translocation between chromosome number 9 and 22, and the untreated CML ultimately will go to a blast phase. So the typical translocation 922, which is the hallmark of a CML patient, and this is how a fish actually looks like when you have this translocation occurring. And fish is a very important tool in the hands of a molecular biologist, and I'll come to that why. Because of the fact that there are various breakpoints which occur, while the P210 is the most common one, and minor also is there, which is associated mainly with ALL. But then you have others also, and if you are using a PCR as your first line thing, if there is an uncommon kind of a breakpoint, you might miss it out. So fish is definitely one of the tests which is going to continue for at least some more time till NGS actually picks up before going for a quantitative PCR for monitoring purposes. So the most common form of the BCR-ABL transcript is P210, and at baseline, this is the most common variant which is present, and the molecular response to the TTIs has been the maximum for the E13A2 and E14A2. So the qPCR results can be expressed in various ways, and the earlier method was to go in for a report which has percentage ratios to either of the control genes. You could use ABL1, BCR, or GUS. And now the trend has been shifting to the reporting with international scale. And the international scale has been established to standardize molecular monitoring across different labs. The earlier trend was that the lab needed to first calibrate itself to the Adelaide lab. And we have been reading Dr. Su's papers for a long, long time. But now certain other calibrators are also available in the market, and the WHO standard is also now available. And each lab needs to calculate its calibration factor, and the percentage ratio for BCR-ABL is multiplied by the calibration factor to derive the report in the international scale. And the calibration factor differ from lab to lab. So the NCCN guidelines clearly now say that at what reduction of the international scale, what you would monitor the response as. This is the new chart which has found its place in the 2021 NCCN guidelines. So the report format should clearly say that what transcript has been detected, and it should also give you the percentage ratio as well as the international scale ratio. This ratio is definitely important for monitoring purposes, but it is also very important to know what is the limit of detection for each negative case. So in this case, if you get a negative case that there is no copies of the BCR-ABL detected, then ABL copy number plays a major role, and each report should carry the percentage ratio of the limit of detection for this particular patient. So this actually is derived from the ABL copy numbers, and we assume that we are not going to go below 10 copies of BCR-ABL transcript. So this ratio plays a very, very important role in cases where we are reporting a negative case. This is the standard format which we have, which tells you that how this patient has been progressing. And the assay sensitivity can be determined for each of these samples which we are reporting out. So the lab should participate in various proficiency testing programs, and the international scale calibration across various labs is compared by taking part in these proficiency testing programs. So this gives a lot of confidence to the lab as well that they are reporting correctly. So the NCCN guidelines now also mention that when this testing needs to be done and what method should be done at each stage of the diagnosis. So NGS is the more comprehensive way forward. Dr. Su has mentioned that a lot of mutations are occurring and would define in the coming years what we see. So we do have a panel, the OncoMyeloid panel, which covers all these fusion drivers, the hotspot genes, and it also uses various expression controls. So for a CML kind of a panel, we do cover all these different genes which are of relevance and would be finding fit in the coming years. And within the BCR-ABL, different kinds of fusion partners could be there, and various breakpoints are there, which are all covered by this panel. And this is how we are able to see on the computer screen that there is a fusion which has occurred. And this is the IGV view of the same patient. So the report format actually carries that, okay, this is the fusion which we have detected, and these could be the therapies of choice, and the clinician is free to choose from these therapies. So just to conclude, the individual gene testing is still going on, but we need to graduate to multi-lead gene testing in view of the limited time which we have at our hand. The RNA-based sequencing will fill in the gaps between the limited target fusion detection, and the NGS is going to find more and more takers in the years to come. Thank you.
Thank you so much, sir. Now I request Dr. Ratima Kohli to please give the vote of thanks. Over to you, ma'am.
Thanks a lot. Thanks a lot, Dr. Atul, for this session. I am from Dr. Lalpath Labs. I would just like to inform that at a very affordable prices, we are conducting MRD, BCR-ABL, as well as quantitative BCR-ABL, wherein we are giving international unit, as Dr. Atul has said. So for any projects or if there are any poor patients, so we are there to support on that basis. We have a very good pricing also available for the BCR-ABL quantitative testing. I would like to thank Professor Susan for being there and elucidating us with all the information. Thanks, Dr. Hemant, for this panel discussion, moderating this panel discussion. Thanks a lot, Dr. Puneet, Dr. Rajesh, Dr. Soumya, Dr. Ganesh, Dr. Shilpa, Dr. Jyotip, and Dr. Prashant. Thanks a lot, Dr. Atul, for giving the perspective of diagnostics with LPL. And thanks a lot, Dr. Purvish, for being there. Now we can close, and it was a very informative lecture. Thanks a lot, everybody. Thanks a lot, all the participants.